cases has now been reduced to 116 from over 1,000 last week, as we work through the backlog, either confirming them or ruling them out. In Uganda, there is 1 confirmed death and 15 confirmed cases, including a Congolese resident who traveled to the United Arab Emirates and then to Uganda. WHO is working with public health authorities in Uganda and the UAE to gather additional information, assess the risk of exposure during travel, and to facilitate contact tracing. We thank both the UAE and Uganda for their collaboration to mitigate the risks related to this case. In addition, a US citizen who was infected in DRC is still receiving care in Germany. WHO's risk assessment remains unchanged, very high at the national level, high at the regional level, and low at the global level. The outbreak had a big head start, and we're still behind, but under the leadership of the government of DRC, we're catching up. In Bunia, there are now 3 treatment centers with a capacity of 80 beds, and there are also treatment units in Mangwalu, Raumpara, Beni, Goma, and Bukavu, and more are on the way. So far, 6 people have recovered in DRC and 2 in Uganda, showing that people can survive Ebola if they have access to care and go to health facilities as soon as they show symptoms. But we still face several challenges. First, testing. One of our key priorities is to scale up laboratory and diagnostic capacity to reduce delays in case confirmation and support faster response decisions. Accordingly, we're working to decentralize laboratory and diagnostic capacity in priority locations, including Mangwalu, Beni, Aru, Yaoundé, and Chomia. We also need to scale up readiness, including surveillance, laboratory diagnostics, and access to health services in neighboring provinces and countries. Second, contact tracing in the DRC is not yet where it needs to be. Only about 45% of contacts have been followed up, and to get ahead of the outbreak, we need to get that number up to above 90%. Insecurity, displacement, and mobile populations make contact tracing especially difficult. Third, blanket travel restrictions imposed by some countries are disrupting supply chains and hindering the response. WHO recommends exit screening at airports, ports, and border crossings to prevent the exportation of cases and contacts. We ask countries that have imposed blanket travel restrictions to lift them. Fourth, community mistrust is a serious barrier. Some community leaders told me that they believe Ebola is not real. Building trust with the communities is therefore critical to bringing the outbreak under control. And fifth, as you know, we're fighting this outbreak without vaccines or therapeutics. WHO and partners are working on advancing clinical trials as quickly as possible.
So my question was about in general, about the material, the personnel, if you see any shortages on the ground, on what on the most critical needs, and in particular on the tests that can detect this particular strain, the Bundigungyo. What can you tell us about that?
So far, WHO, we have deployed 106 staff in the field, and that are distributed in 3 provinces. But at national level, we have a lot of infrastructure that has been infected, and we are putting those personnel in quarantine. That means there will be a shortage of national personnel in those places. And we support the Ministry of Health in order to take other healthcare workers in other provinces in order to replace those personnel in the province. Yesterday, we have 30 healthcare professionals arriving from Kinshasa in order to support clinical care here. And regarding on the test, WHO supported the Ministry of Health to have 2,000 tests that has been deployed already in Bunia.
What the field team is doing, looking clearing the backlog. So the lab so far has done 1,445 tests that cleared almost all the backlog we had. And every day, as the surveillance improves, there are new suspect cases. So today we have 116. The historical 223 deaths, there's a dedicated team going through that case by case, whether it's a probable, whether it's a discarded, or unknown. So that work is going out on the field. So the numbers are there and they have not missing from the overall. It's just the work required. At the start of the outbreak, every death was included.
How much money is still needed to help fight this outbreak?
Firstly, just to say that at the start of the outbreak, we immediately, the Director General released $3.9 million from our contingency fund for emergencies. This is a very important fund that enables us to start any response. So that's what we've used to start the response to the outbreak. Currently, we estimate our costs, our needs for the initial 3 months of the outbreak to be $115 million. That will be part of a strategic preparedness and response plan that is being launched on Friday, done together with our partners in Africa CDC, the Democratic Republic of Congo and Uganda and all the other partners that are part of that response. So this is what WHO needs, but it's part of a much bigger requirement for the total response. Of what WHO needs, of that 115, we are only 35% funded at the moment for this initial period. And considering the scale of the outbreak, we estimate we will need a lot more for the duration of the response. However, we are doing the very best we can with what we have. We have mobilized fully to the field, supporting the government and working with many other partners.
If I could, the first for the DG, Dr. Tedros, do you have thoughts about the U.S. plan to establish a quarantine and early treatment center in Kenya rather than allow Americans who may have had exposure to Ebola in the outbreak zone to return to the United States? And the second question would be for Dr. Murthy. Could you tell us a little bit, please, about the status of trials for the antivirals and other non-vaccine medical countermeasures? Thank you.
We're working with the US. We collaborate at all levels, expert level and high level. We share information, and they're also investing, they're supporting financially. And I know they will increase their support. There is strong commitment at all levels, and I'm really glad to see that. So for the response, I think that's the most important part. With the rest of what they're doing, I think based on their risk assessment, they have, they can do whatever they think is right for them. But I really appreciate actually the strong commitment and support I see in responding to this Ebola outbreak, and I'm in touch, including my level, by the way.
The two agents there are MBP-134, promising Ebola monoclonal antibody, and remdesivir, which in the trial there are multiple arms, including a combination of those two. So that is most advanced because that protocol was written before this outbreak, and we were able, as a preparedness protocol. So the fact that we have these preparedness protocols approved before outbreaks is a development. Secondly, when we consider prevention of cases, we're certainly not waiting for the vaccines, in that we have another new development for an Ebola outbreak, and that is an oral antiviral. So obeldesivir, we haven't had this before in any previous outbreaks of viruses. We have an oral option for research Here, I would like to point out the really close coordination between leadership from the national authorities in DRC and Uganda, Africa CDC, and ANRS, which is the lead filovirus cork that we have, collaborative open research consortium, with the R&D blueprint works with to collaborate with scientists. All of these partners are coming together to write the protocol for a clinical trial looking at obeldesivir as a post-exposure prophylaxis. And again here, very close coordination with those working in the field for contact tracing will be very important. I think there is a possibility looking at this in a positive with contact tracing. We will be able to offer potentially beneficial option to the contact list in this clinical trial. So the protocol and in fast development, it will still be at least 2 to 3 weeks before we can start that protocol.
And of course, the last is, which makes again this outbreak or epidemic complex, is the virus. This type of Ebola virus is rare. And since it was discovered, it's 19 years. And 2 outbreaks. The first one was in 2007, the first ever. And then the second was in 2012. And of course, there was like 16 years with no cases. And the test kit was not optimized for this rare type of the virus. But at the same time, not enough cases, although we have candidate vaccines and treatments, but not approved vaccines and treatments. That adds to the complexity. And of course, the other part is the symptoms of other disease, which is very similar to this disease, especially malaria, is very, very prevalent in the area. And the health workers we have spoken to actually reported superinfections. You know, you find someone positive for malaria and you treat for that, but in addition to malaria, that person has